Thank you for joining us for today's presentation, Diabetes Disaster Prep, a Quality Improvement Project by Stacy Rory. Recent natural disasters have spotlighted the need for emergency preparation in America. With Hurricane Charley in 2004, Hurricane Katrina in 2005, and the devastating California heat wave in 2006, public health officials have begun to recognize a need for targeted and focused disaster preparation training for vulnerable populations, including those with diabetes. Recognizing that primary providers of healthcare have a duty to complete disaster education as part of a health education plan is crucial for improving overall patient care. This Quality Improvement Project, or QIP, was designed as an integration of Diabetes Self-Management Education, or DSME, and Diabetes Self-Management Support, DSMS, to empower patients and family in disaster readiness preparation, and to promote internalization of the need for preparation to prevent this health disparity during disasters. The QIP explores the special needs in primary and tertiary level emergency prevention for rural patients, specifically for patients with diabetes, and aims to demonstrate decreased vulnerability of community participants who prepare for disasters. This QIP was approved by the Institutional Review Board at the University of South Alabama and given exempt status. Data reported from Hurricane Katrina demonstrated a twofold increase in acute disease symptoms such as ketoacidosis and hyperglycemia, and a threefold increase in severity of symptoms in patients presenting to shelters with known chronic disease. Additional data collected by researchers post-Katrina suggests rising mean A1C levels throughout long-term observational periods, even long after other health measurements, including blood pressure and lipid levels, had returned to normal. The estimated lifetime cost for losing diabetic control during Katrina is $504 million for the entire affected population, between $2,270 and $5,243 per individual patient. Current shortages of medications in both pharmacy and community response agency supply lines will further complicate the ability of patients with diabetes to acquire needed medications during disaster situations. Rural communities have the greatest need for personal preparation training due to lack of community resources and long-term implications for wellness and life expectancy in patients with chronic care needs. Every person needs an emergency preparedness plan tailored to the specific needs of the individual. For the patient with diabetes, the preparedness plan must include diabetic-specific instructions to minimize short and long-term social, physical, and psychological impacts of the disaster experience. The QIP recognizes patients with diabetes have increased vulnerability during and after disaster situations based on the need for daily medication and a specialized diet. Interruptions in diet habits during a disaster, including lack of adequate carbohydrate-controlled food sources, disruption of water supplies, and increased physical and emotional stress, result in poor glycemic regulation and control both during and post-disaster. Primary providers serve two essential roles in the preparation process, as both an example of preparedness and as a patient resource for creating a personal preparedness plan. The QIP endeavors to establish a change in primary practice to focus providers on patient education for preparation. To accomplish this change, the clinic first focused on tertiary preparation, including establishing a clinic emergency and disaster plan. Second, the change addressed primary preparation to include provider emphasis on the importance of DSMS and how to prepare a personalized diabetes emergency plan, essential to patient internalization of the need for preparation prior to a disaster and preventing complications post-disaster. DSME and DSMS for maintaining an emergency supply of diabetic medication, diabetic foods, and water, self-management of diabetes, and general health care are essential components to the specialized individual emergency plan. The QIP began with an introduction to the clinic staff and support personnel on the importance of disaster preparation, maintenance of personal disaster kits, commitments by staff members to prepare personal kits for home and clinic use, and review and redesign the clinic disaster plan. The QIP used a convenient sample of patients from the Women's Wellness and Maternity Center in Madisonville, Tennessee, which represents one of many rural communities to recently suffer the consequences of a natural disaster. The project used a patient questionnaire modeled after the Kentucky Diabetes Prevention and Control Program questionnaire to establish baseline levels of preparation awareness in both existing and new patient populations. All patients presenting to the clinic for care were given the initial questionnaire in conjunction with registration paperwork. Patients electing to complete the voluntary questionnaire were given FEMA brochures and pledge cards to review with the provider during the visit. Community introduction activities included advertisement and project flyers distributed by the QIP organizer to promote the free Diabetes Disaster Kit class in conjunction with the QIP. Patients and clinic staff who self-identified with diabetes or risk factors for diabetes were asked to join the QIP. Participating patient identification included the first 25 patients who registered for the free course on disaster preparation. Limitations on preparation were placed only by age. Patients and staff 18 years of age and over were included in the QIP. Patients under 18 years of age were excluded from participation in the QIP. During checkout, the front desk staff asked patients to sign up for the disaster class prior to leaving the clinic. The redesigned clinic disaster plan was modeled to meet FEMA national standards for preparation and included outlines for annual practice drills. The first practice drill took place within 3 months of the QIP introduction. Finally, the QIP conducted a class including the projected 25 participants who elected to attend the diabetes-specific disaster preparation activity presented by the QIP organizer. This class lasted approximately 1 hour with participant questions and was guided by the Kentucky Diabetes Prevention and Control Program curriculum. The course was offered to this statistically similar community for no cost and facilitated by the QIP organizer and took place in the clinic education room. The course covered the creation of a basic emergency plan for home, work, and school, completion of a family communication plan for all members of the family, and preparation of an emergency supply kit to include typical items suggested by ready.gov and additional diabetes-specific items such as foods, medicines, and diabetic care needs. Failure to meet the standard of education and support concerning disaster preparation for diabetics has led to significant deficits in diabetic control during and after natural disasters. Patients do not internalize the need for preparation and establishing a reserve of medications related to chronic conditions. Advanced practice nurses, including the DNP, hold the public trust and can convey the needed education to meet preparation needs. Advanced practice nurses have a strong foundation in health promotion and stand at the forefront of focused disease prevention and disaster preparation. Data collected by the QIP organizer and clinic staff pre- and post-class was compared using SPSS software and reviewed by a statistician. All invited course participants were diagnosed with diabetes prior to course invitation. However, this was not a requirement to participate. All participants completing the pre-class questionnaire responded they had never received information regarding disaster preparation in general or diabetes specific from their primary provider, and this was a motivating factor for attending the course offering, but this was not used as an exclusion for participation. Using a frequency table, it was found 60% of participants responded in post-class phone interviews they had prepared a disaster kit for diabetes, including diabetic medications, Chart 1. The QIP is considered effective since more than 50% of participants reported preparation of a kit including more than 3 days of diabetic supplies, which is statistically higher than the national reported average of 20 to 38%. A tornado severe weather procedures drill was completed since this is the highest rated disaster probability for the rural area. Staff and the QIP organizer completed the drill evaluation form included with the planning packet and considered the drill portion of the QIP successful. Each procedure listed in the tornado severe weather procedures drill was accomplished safely and in a timely manner according to the guidelines from the revised FEMA compliant plan. The American Diabetes Association recognizes the need for development of a diabetes-specific disaster preparation kit in the published preparedness guidelines. Failure to meet the standard of education by primary providers and lack of support concerning disaster preparation for diabetics has led to significant deficits in diabetic control during and after disasters. The QIP identifies a gap in primary provider education concerning disaster preparation for diabetes. Assessment of the need for quality improvement in practice is evidenced by the examination of diabetic patients after Hurricane Katrina. The research detailed by Fonseca and her colleagues indicates significant loss of diabetic control as measured by A1C, a loss of significant life expectancy, and increased cost of care for patients with diabetes post-storm. Need for change is further supported in the research by Carmelli and colleagues, stating half to two-thirds of patients presenting to disaster shelters do not have needed medications, proving diabetic patients are not only particularly vulnerable during disasters due to the need for daily medications and diet control, role, but also face a lack of education for diabetes-specific disaster planning. The QIP patient responses of 0%, having previously received education regarding disaster preparation, are consistent with the generally reported lack of primary provider provision of education regarding diabetes and disaster preparation. The doctor of nursing practice is uniquely prepared to spearhead a practice change to promote the need for clinic disaster preparation and specialized education on disaster preparation for patients with diabetes. The QIP suggests investment in individual disaster preparation education will positively result in preparation by vulnerable patients and decrease patient as well as community vulnerability, while increasing patient and family resilience in times of disaster. Preparation of families for disaster synergistically aligns with the rural clinic mission and vision by strengthening the overall family and empowering the most vulnerable family members to repel the stresses of an acute disaster situation. Given the weather history of the rural area, adherence by providers to the FEMA guidelines for disaster preparation education is essential in stabilizing this rural community before, during, and after severe weather events. Focusing general preparation education toward all families while strengthening the most vulnerable members of the community through preparation education focused toward diabetic needs will reduce the immediate and long-term impacts of future weather events in the rural area. This QIP increases the knowledge base for providers on diabetes disaster preparation, empowers providers, and enhances primary care practice in the rural setting to meet the needs of these vulnerable populations. Thank you for joining us for today's presentation, Diabetes Disaster Prep, a Quality Improvement Project, by Stacy Rory.